All right, everybody, welcome back to Little Brain Campaign Podcast. I am your host, Dr. Lauren LaRose. I'm a board-certified child and adolescent psychiatrist and adult psychiatrist with a private practice in Metairie, Louisiana. And I have here with me today Dr. Alice Hoyt, who's a food allergy specialist, and we're going to get all nitty-gritty on food allergies. So thanks for being here, Alice.
My pleasure. Thanks for having me.
Okay, so give us a little background of how did you get to be a food allergy specialist?
Absolutely. So growing up, spent a lot of time on my grandparents' farm, and they grew a lot of wonderful foods. And I didn't know how interesting it was at the time, other than it's cool, but I kind of thought it was kind of the norm. Fast forward, going to college, majored in nutrition because I knew I wanted to go to med school, but I wanted to have a really good backup plan where I could still serve patients if I didn't get into med school. But I did get into med school, which was awesome, and ended up going into what's called med-peds, internal medicine and pediatrics, so I could take care of, we say womb to tomb, everybody from pregnancy on to very older years. And in that time during med-peds, I love being able to take care of all ages. But I really wanted to niche down into certain conditions and really those that involve the immune system.
Yeah.
Because I've always just been fascinated by the way our environments and our immune systems interact.
Yep.
And one of my mentors suggested that I look into allergy and immunology. And I'm like, well, what is that? Because doing med-peds, we do a lot of ICU, not a lot of more of the outpatient types of specialties.
Right.
So I did a rotation. I was like, oh my gosh, this is what I love. And then did fellowship at University of Virginia, where they definitely teach you to think outside the box.
Yeah.
Was very encouraged to do a lot of food allergy research and also community outreach. And I just found my passion for how to serve families.
Yeah, that's amazing. Okay, so tell us, so you're in private practice.
I am.
Also in Metairie,
Yep.
just like me. So how do patients come to you? Do they already suspect there's a food allergy, or are they just having a bunch of problems and they're trying to tick this off the list? What does that look like?
So at first when I started my practice, because I had been at Cleveland Clinic and dream job there, helped launch their food allergy center of excellence there, and loved it. And I would get a lot of referrals from pediatricians. And so when I moved back home, and there wasn't so much the appetite here for food allergy that there was at the Cleveland Clinic.
Yeah.
So started my own practice, and I thought I would kind of have the same model, but actually have a lot of referrals from my fellow allergists because there's not that enthusiasm for food allergy here. The big centers aren't really doing much of it.
Yeah.
And so a lot of my patients do already come to me with a really great evaluation from one of my specialist colleagues. But some patients also come from a pediatrician, come from the internet, you know, Googling food allergy and trying to find somebody to help them, to help their child. So they come in a range of having a very complete workup, and we can spend a few minutes really confirming all of that history and the diagnosis, and then dive right into treatment plans, options for their kiddo. But then there are also kids who come to see me that have not been evaluated, and either their pediatrician sent them or their mom or dad just said something's going on here. And the interwebs can find a lot of information and found me.
Yep. Okay. So when you have a kid that's where there's a food allergy, what kind of external symptoms are you seeing? How does that present?
So there are multiple types of food allergy conditions. And how I kind of break it down is this an anaphylactic type of food allergy?
Okay.
Or is this one of our other food allergy conditions that does not use all of those mechanisms of anaphylaxis? So completely different disease processes.
Okay.
So the most common types of food allergies are anaphylactic ones, the classic peanut allergy. A kid eats a peanut, hives, swelling, trouble breathing, vomiting pretty quickly. Usually that's starting within 15 minutes, maybe within 2 hours. That's kind of the window. Those are quick onset. There are other types of food allergy conditions, though, one being FPIES, food protein-induced enterocolitis syndrome, where a little baby will eat a food, looks great, goes down for nap time, and then anywhere from 1 to 4 hours later, just wakes up vomiting, crazy vomiting.
Okay.
Can also have diarrhea. These kiddos lose so much volume so quickly that they start to look floppy, septic.
Oh, wow.
They look so sick. They get rushed to the ER. Usually they can be young, but usually they're 6 to 12 months old.
Okay.
So they're being evaluated for septic shock.
Right.
Because also losing all that fluid, you can have drop in blood pressure.
Yep.
Like they just look not great.
Yeah.
And they get fluid resuscitation and suddenly they're like looking awesome. And we're like, what just happened?
Right.
And oftentimes it's a food that the kiddo had already had and tolerated.
Huh.
And so that's another type of food allergy. It's not an anaphylactic food allergy, meaning that the allergy cells that cause the high swelling, trouble breathing type of food allergy, those mast cells, those are not the same cells that are involved with FPIES.
Okay.
So that also means the treatment is different. So epinephrine is absolutely the first line treatment for anaphylaxis.
Right.
Epinephrine is not the treatment for FPIES.
Right.
Because the epinephrine stabilizes the mast cells. We're not dealing with mast cells and FPIES.
Okay.
So those are two of the common food allergies that we see. We also see what's called eosinophilic esophagitis.
Yes.
Which
I've had some patients have this recently.
Oh
This
my
is very
gosh.
interesting. Okay.
I don't know. I hate to say like what's in the water, but like part of me actually wonders what's in the water.
Why is this popping up?
It is totally popping up.
Uh-huh.
Now I am very diligent about screening, not just patients, like asking about, do you spontaneously vomit? Or asking the mom, like, does your kiddo just randomly vomit?
Yeah.
Ever feel like food is getting stuck? Has to drink a lot of water, slow eater, or eats like a bird. Sometimes even picky eating. Picky eating to me, so many times it's not just like a child's being picky. So many times there's an underlying cause for it.
Okay.
And I'm seeing more and more that it can be eosinophilic esophagitis, which is basically like eczema of the esophagus. And so you can imagine inflammation in your esophagus and then wanting to like chow down on some food. Food gets stuck.
Yeah.
And you're not choking on it, but it's stuck in your swallowing tube.
Yeah.
And that's the result of many days, months, sometimes years of that inflammation in the esophagus tightening it down.
Okay.
So that can be related to foods. About half of the time, if we have patients stop consuming milk products, it can get better. But so that's how we can have different types of food allergies and why it's so important that, or food allergy conditions, it's so important that somebody sit down with a board certified allergist, especially one who has a lot of interest in this field, in food allergy in particular, because there can be nuance to the symptoms.
Right.
And we have so many more treatment options now than ever before.
Right. Okay. So I want to dig in on both the eosinophilic esophagitis and what was the second type of allergy that you said?
FPIES.
FPIES. Okay.
Yeah.
Let's start with that since you mentioned that one first. Okay. So like, how does that develop? How does that happen?
It's a great question. Nobody knows why any of these are happening.
Okay. Okay.
That's it. No one knows. No. So what I typically say is, and tell my patients, you know, Job of the Bible, he had a lot of bad stuff.
Yeah.
His kids had a lot of bad stuff.
Yeah.
None of them had food allergies.
Yeah.
They weren't there. We really didn't see allergies like itchy, drippy, sneezy from pollens until the 1800s. That's when things started to be reported, late 1800s. And then when you start to look, and there's a beautiful article by one of my mentors, Dr. Thomas Platts-Mills, in the Journal of Allergy, Clinical Immunology, I think 2015, called The Allergy Epidemics.
Yeah.
And he was asked to write an article, The Allergy Epidemic, and he said, no, it's the allergy epidemics. Like these are different processes. Yes, they're all allergy, but they're different.
Yep.
And so we first saw the onset of the concept that our bodies are responding inappropriately to the environment.
Yep.
Pollens. Then later we started to see children having asthma from dust mites. Then we started to see more food allergies. Really, we didn't see a lot of food allergies. The early 1900s, there's a great report in the, I think it's in the Lancet in 1908. That's actually the first report of doing what's called oral immunotherapy, meaning teaching the immune system to tolerate a food that it wasn't tolerating, was having high swelling, trouble breathing when you ate it, and they desensitized this kid. But there wasn't a lot of food allergy then.
Yeah.
And then something happened, and in the 1990s, the uptick in peanut allergy was noticed.
Yeah.
So then the brains got together and said, oh, well, let's have kids avoid foods until they're like 1 or 2 or 3 years old, depending on the allergen. That was the major recommendation that came out in 2000. And then what did we see? Then we saw a major uptick in all of the food allergies.
Yep.
So then in 2008, the AAP kind of quietly walked that back, but there really wasn't data on what really to do.
Yeah.
We had totally over-medicalized how we feed children, which is totally a problem right now today. I mean, a baby food aisle?
Yeah.
It's crazy.
Yeah.
It's crazy. And so in 2014, 2017, that's when we started having more data, especially the LEAP study, learning early about peanut, that kids, especially kids at risk of developing a peanut allergy, kids who have eczema or kids who have atopic dermatitis, pretty bad atopic dermatitis, those are risk factors for peanut allergy. If we introduce peanut early, we can actually, like, starting as early as 4 months. So we're talking about taking peanut butter and diluting it with breast milk.
Yeah.
Making it appropriate. We're not feeding kids peanuts.
Right.
But getting the foods into the diet sooner rather than later to teach the immune system to tolerate it. And we are starting to see that maybe food allergies are on the decrease, depending on what article you read. But it still doesn't answer why we had the uptick in the 90s. And even though we think about 77, 80% of peanut allergies could be prevented by early introduction, what's up with that other 20%?
Yeah.
I think that other 20% is that same group from the 1990s where we don't know what started it.
Do you have a theory?
I have theories.
Okay.
And, you know, a lot of people will talk about the hygiene hypothesis, which is basically like, we're very clean.
Yeah.
You know, up until very recently, the most common cause of death for humans was infection.
Yeah.
Well, we have the onset of antibiotics. We have vaccines. We have hand washing. We wear shoes.
Yeah.
You know, we're a completely different, like, host.
Yeah.
Right?
Yep.
Than even 100 years ago.
Yeah.
So our immune systems, they're being tasked with different things now, and they're not being tasked with things that they were before.
Right.
So, you know, what exactly is it one thing? It's hard to pinpoint one thing that could be causing it. I will say that it is interesting to look not just at our hygiene now, but if we really look at our ancestry and we really think about, you know, when we were in our mom, what was she being exposed to?
Yep.
Right? And then when we were an egg inside of our mom, developing with her mom,
Right.
what had her mom
Yep.
been exposed to?
Yep.
And what type of changes? We're learning so much more now about epigenetics and how environment impacting our genes.
Yeah.
Activating genes, deactivating genes, all of this. So I think it's complex. We have to try to follow the data wherever it goes, even if it's unpleasant.
Yeah.
An unpleasant area, I think, is really looking at the impact of adjuvant vaccines in the development of food allergy. We know that if I want to make a mouse allergic, I inject them with alum, and it revs up IgE. It can sensitize them. And so when I also give like egg or something at the same time, we know that in the vaccines, because one of my fellowship projects was testing vaccines for whether or not they contain the allergens, and they don't.
Yeah.
It's not that. But we give vaccines very early now. Vaccines are very important, don't get me wrong.
Yeah.
But every pediatrician needs to have a good reason why the child in front of them needs that specific vaccine. And you know, it's okay to have the conversation with mom, like, look, I don't think your child's going to get this, but it's a very low risk vaccine. We don't want your kiddo to get it, and we also don't want some of these other kids to get it too. I think it's very appropriate to have that public health discussion with the parents.
Yeah.
But I don't think it's appropriate to sort of guilt parents or shame parents and not be honest about some of the reason to vaccinate is because we do want to protect kids who are more vulnerable to some of these disease processes. Just have an honest conversation about it. But getting back to causality, we can absolutely see some increase in IgE production when we're giving adjuvanted vaccines, because we're revving up the immune system to attack. Some of that, it comes down over time. But how is that playing a role? Do I think it's causal? I don't necessarily think it's causal. But do we need to have that conversation, and do we need to investigate? We do. We need to have honest conversations. We need to have honest studies and go from there.
Right. And just understand it. I think our problem is that, like, when these medical questions become, they like leave the medical arena and become political, it becomes very black and white and like polarized when it shouldn't be. Like, it should just be, I mean, we were trained, like, you have a hypothesis, you test the hypothesis, right? Like, it should just be a scientific question.
Right.
And there's always going to be, like, in science, we usually don't come up with a definitive answer, right? We test a hypothesis, and then we say, this data from this research study shows us this.
Yes.
Right? And then we can do the research study a little bit differently over here, and it might show us different data. Right? And so
in different populations.
Exactly.
Yes.
And so like, in science, we're rarely definitive about things. But then when it leaves, like, the medical arena, all of a sudden it becomes so definitive either way. And I think that's what the problem is.
Yeah, and everything has to be like a soundbite.
Yes.
And not everything
should be.
Is soundbiteable.
Correct.
There's a soundbite.
That it's so much more nuanced, and we're not realizing that, like, every little human body is different.
Exactly.
Every human body is different from every other human body.
Right.
And we should treat it as such.
Yes.
But we, for a lot of good reasons, we have to a lot of times kind of generalize things. But the problem is that there's going to be kids who are hurt in the process if we generalize,
Right. And so having that conversation about risks, benefits, and alternatives, and being honest with parents. Instead of trying to, like, hit them over the head with, you're an anti-vaxxer if you want to separate out your vaccines a week apart or something. Like, that type of attitude, in my opinion, from a doctor is going to push families away.
Yeah.
So let's meet parents where they are, ask what their questions are, and show them the data.
Yeah. And remembering that, like, a parent may not be the medical expert. Unless you have a parent who's a physician. The parent might not be the medical expert, but the parent is the expert on their kid.
Yeah.
Like, I think we have to remember that. That parents know their kids best.
Yes.
And, like, the parent should be able to make decisions for their child with the guidance of
a million percent.
Yeah.
Right? Like, the doctor, hopefully, if you're watching this, you're plugged in with a pediatrician that you trust, that you can have an honest conversation with. I mean, that's how the doctor-patient relationship is supposed to be. It's supposed to be me having an honest conversation about what diagnosis I think your child has, or what your child needs at this well baby appointment, and why your baby needs this, and you giving me feedback on, well, this is how I feel, or what do you think about this, or I read this on Facebook, or whatever the case may be, and being able to have that honest discussion. And I think we've really, really lost that. And the doctor being able to be flexible and humble enough to say, you know what, I haven't read that. Let me go read it. Right? Yes. Yes. That's so hard for us, right? It is. But it's so important. It's so important. And that's one reason I'm very blessed to know allergists across the country, across the world, actually. And we have this whole network, this whole email list, and we have a meeting every June. And we're just constantly sharing cases. Like, we'll text each other. We have a case conference, like, all these things, all about food allergy. Because kind of getting back to my training in Charlottesville, that's where they first identified alpha-gal allergy, which is the kind of strange allergy where you're bitten by a tick. Okay. And then 2 months later, you develop allergic antibodies to a sugar found in non-primate mammals. So, like, not in us, but, like, in cows, in pigs. Okay. And so then, like, you eat a cheeseburger, And 6 hours later, you have delayed, also unusual, anaphylaxis.
I've never heard of this
So
before.
they would have
Okay.
patients, Dr. Platzmills would have patients coming in saying, I eat meat and 2 hours later I get hives, or I have like X, Y, and Z, anaphylactic reaction. And like that sounds absolutely bizarre because meat, pork, like those aren't really common out. It's not a peanut, it's not a tree nut, not egg, milk, wheat, soy, fish, shellfish. And this delayed anaphylaxis, what? Like that doesn't happen.
Yeah.
That doesn't happen, right? So all these things don't happen, but they were happening.
Yeah.
And if Dr. Platzmills, if his team had not listened to the patients, then they would still be these patients would still just be off like, okay, well, I guess I don't even know.
Yeah.
No, what would happen is they would go to the internet and they would find somebody else who's probably not as informed medically, who could cause harm. That's one of my concerns about a lot of the online influencers, all of this stuff, trying to give health advice.
Yep.
You can actively cause harm to somebody.
Yeah.
But, you know, up in Charlottesville, definitely learn to think outside the box, to listen to your patients, and that's going to help you learn.
Yep. Yeah, because you have to be, I mean, I think you have to take time and be like an investigator with this kind of stuff, you know, and like really pick it apart.
Sherlock Holmes.
Yep, exactly. Yep. Exactly. Which is pretty much what I have been doing in my practice.
That's the mark of a good doctor.
Yeah, and it's, I mean, I feel like that's the fun part about being a doctor, you know? I mean, obviously it's not fun to see your patient suffering, but it's like, that's like your scientist part that's like, ooh, I need to like dissect this and like learn about it and figure out and like go read and, you know.
Right. And spend time with them.
Yes.
And that was one thing I really liked when I did that first rotation when I was a resident, is those allergy fellows would spend so much time asking about, do you have curtains in your house? Do you have carpet in your house? Like all of these little questions.
Yeah.
Trying to get really at like the root cause of like what is causing this patient's symptoms. And I loved it.
Yeah. Yeah. So, okay. So just like hopping back to what you were saying about the alum. So is the issue that like, okay, you have this baby who's being exposed to alum in the vaccine, and at the same time they're being exposed to a new food? Is that what it is? I don't think
that's the case.
Okay.
What I think it is when we think about a baby's immune system inside of mom, the immune system is very tolerant, has to be very tolerant. And clearly there's very limited research on this because because we don't even want to think about that, right? Yeah. But for a baby to survive inside of mom, that baby, half of that baby the DNA is totally different from that mom, right? So like if I took my kidney, as you know, if I took my kidney and just stuffed it inside you, it would be immunologically devastating.
Right, correct, yes.
Both of y'all. Yeah. Wouldn't be good. But it really is a miracle that a baby can grow inside of a mom, that mom tolerates baby, baby tolerates mom. And then when baby is born, baby's immune system has to start shifting pretty quickly. Yeah. Because has to start attacking things. Right. Which is why, in part, we give vaccines, because the baby's immune system isn't mature enough to recognize something, attack it. Right. What I think is happening is that something is closing that window of tolerance sooner than what it used to be open. Okay. So when we are saying, let's get peanut in the diet early, let's get egg in the diet early, what we're doing is we're getting it in the diet while the baby's immune system is still willing to be tolerant of it, as opposed to waiting until that critical window, as some of us call it, has somewhat closed. So what are we doing to close that window sooner than we were before? Okay. That is where I am concerned, that are we doing something with, I mean, if we look at the purpose of vaccines, they're so important. It is important to vaccinate kids against these terrible diseases. Yes. It is also important that we have honest discussions and studies. We have the ability to study these things. Yeah. To look at, is there some sort of epigenetic modification that is occurring in select at-risk individuals? Yes. That is potentially facilitating closure of that window
Right.
sooner rather than later. Would that mean that you're not going to vaccinate your kid?
No.
But would it mean that, okay, if we're doing this, then we're also going to do this other thing to
Right.
make sure that we prevent a food allergy?
So what do you think would make certain populations at risk?
That's a really good question.
Yeah.
Because we know some risk factors are a baby having eczema,
Okay.
severe eczema,
Yep.
a baby already having an egg allergy. Those are risk factors that came out of Gideon Lack's work leading into the LEAP study.
Uh-huh.
He had already studied, like, okay, what makes a kiddo who's allergic to peanut, what commonalities did they have?
Yeah.
But I see kids all the time. Yesterday, there's no family history of food allergy. Where is this coming from?
Yeah.
So it's really hard. It's really hard for me to say who really would be at risk.
Right.
I mean, there are some like slam dunks, like, okay, you have eczema. Yeah,
Right.
you're probably at
Right.
risk. Your kid, your older sibling has a food allergy. Your parent has a food allergy. Yeah, you're probably at risk. But there are definitely families that come to see me that are like completely naive to this.
Yeah.
So what is that?
Yeah.
You know, I also see some on the interwebs about you know, how was a baby delivered? Did a baby need antibiotics at birth? Like all of those things I think our minds as moms also go to, because I think a lot of us are always trying to like blame ourselves. If we had done this differently, then our baby wouldn't have this.
Yep.
And we can't do that. Like
Yeah.
this is way too complicated to just say, oh, it's because you had a C-section that your child has this potentially life-threatening peanut allergy. Like it's just, immune system's more complicated than that. And on top of that, your baby might not be here if you didn't have that C-section.
Right.
Or you might not be here if you didn't get those antibiotics. So we're going to play the hand we're dealt.
Yeah.
And let's continue to investigate why some of these things are happening.
Yep.
And let's continue to find good therapies, which is another interesting discussion.
Yeah.
Because now, as you know, so many more pharmaceutical companies are going to long-term treatments as opposed to cures.
Yep. And why would that be?
Money, money.
Yeah.
Right?
Yeah. Long-term patient. If
right.
you cure someone, they don't get to be your patient forever. Yeah.
That's such a big discussion in my world because we do what's called oral immunotherapy or sublingual immunotherapy. So if a kiddo does have, so let's say a kiddo does have a peanut allergy or an egg allergy, it used to be we're like, okay, here's an EpiPen, that's it. But the whole reason I started my practice was because up at Cleveland Clinic, we were doing desensitization protocols. But then when I came down here, there wasn't that enthusiasm for it because it's time intensive. It takes sitting down, talking with patients. There's risk involved, right?
Yeah.
Because you're giving the child small amounts of their allergen in your office, and then they're doing it every day at home outside of your care. And it's in my practice, we use real food.
Yeah.
They bring in Jif peanut butter, Skippy peanut butter,
Yeah.
Peter Pan, whatever it is,
Yeah.
right? Like, and we're able to teach the child's immune system to tolerate it.
Right.
In many cases, get them to bite safe, meaning if they accidentally had a bite of it, they wouldn't have a severe life-threatening reaction.
Right.
But when we start these kids early, like, I'm thinking about that critical window that's closing and say a kiddo has that allergy. Well, when we're starting that early, we're able so many times to get that immune system back on track.
Yeah.
And then that developing immune system develops tolerance as opposed to if we wait until they're 4, 5, 6 years old, we've got a lot more reprogramming to do.
Yeah. Yeah. Okay.
But all of that is using real food. It's not using a drug. And there actually was it's a food, but it was a prescription food called Palforzia. And it was a treatment for peanut allergy. And it is fading away. They're going to stop making it. And the reasoning, very explicitly, they said it's not a quality issue. It's not that it's not effective. The issue is the allergists who are in the weeds treating patients with food allergies, we don't need that.
Yeah.
We can use a real food. Parents prefer to use a real food.
Right.
And then the allergists who weren't so much doing OIT yet, the product was not the easiest to work with. It had refrigeration. It was mailed to the patient, but then they were only mailed that one dose. And then if they had to go back on a dose, they had to come to your office to get it. Well, there are not a whole lot of allergists in America compared to the amount of food allergy we have. So some patients are driving 3-4 hours.
Yep.
They're flying to centers of excellence. So the concept that we're not as much looking for cures, and I mean, I get it from a business standpoint. Like, why would they look for a cure? Right? But it's, healthcare, it's a whole new world right now. And what I'm really hopeful about is that we do have more treatments and that we do have more minds. And I think this latest generation where they have everything at their fingertips. I mean, they can just push a button and toilet paper arrives on their doorstep.
Yeah.
You know what I mean? Like, amazing. Whereas our generation, like, we came up, we didn't even have Facebook. We had an Oregon Trail on our Apple IIc.
Correct.
Right?
Yeah. I could only access it at school. Yeah.
Yes. Yes. So we have so much potential.
Yeah.
To make so much good impact.
Yeah.
But we have to ask the honest questions. And we have to have open conversations. With our patients.
Yep. Okay, before we end, I want to talk really quick about eosinophilic esophagitis. It's funny that you mentioned that because, like, I had one patient. It was like a new patient, maybe 3 or 4 months ago, and the kid had that, and I was like, eosinophilic esophagitis. I'm like, I don't even know if I know what that is. So I had to, like, go read about it, and then all of a sudden, I had 2 more patients pop up with it. I'm like, and I have never heard about this before. In all of my 8 years of private practice, I'm like, what is going on?
So the first question is like, oh, well, is it just because now people know about the diagnosis?
Right.
Some of it, I do think, like, our colleagues are becoming more informed.
Right.
But you don't make up that, like, food is stuck.
Yeah.
Kind of like you don't miss that, right? Just like you don't miss anaphylaxis. Like, some people ask, is food allergy really increasing? Well, when you look at the incidence of anaphylaxis in the ERs, that has increased.
Yes.
And anaphylaxis is objective.
Yeah.
So these are objective findings that are increasing.
Mm-hmm.
And now more doctors know, 1, to look for it, and 2, how to look for it.
Yeah.
Which, unfortunately, right now, the only, like, really good test for it is an endoscopy, where the patient has to be sedated, the GI doc goes down and takes little biopsies and is looking for these allergy cells called eosinophils in the esophagus. And this happens in little kids. This happens in adults.
Yep.
When I tell you how much more and more of this I'm seeing, it is alarming.
It is.
It is alarming. What do I think is causing that? I think we have a big problem with putting things in our mouths or things going down our swallowing tubes that should not.
Yeah.
Excess detergents, hand sani, all these things that are not meant to be eaten that we're putting on our hands.
Yep.
Not good.
Yeah. So it's like we're putting those on our hands and then we're eating food. We're
Yeah.
sanitizing right before we go into the cafeteria and then we're eating.
And we're eating
lunch.
the sanitizer.
Yeah.
And then if you think about, like, residual detergent, we know if you, like, rub detergent on your skin, that's not good.
Right.
It's not good.
Right.
We know, like, for our kids with eczema, like, as little soap as possible and get the soap off as soon as possible, right? Because the soap's going to impact the already delicate skin barrier. So say, like, you put your coffee cup in the dishwasher, it doesn't quite get all the detergent out, and then you make your hot coffee with milk in it, and then you drink it down, and just, it's hypothesis.
Yeah. So what is your treatment? Like, what do you do for the kids that come in with eosinophilic
So there's sort of,
esophagitis?
like, 4 approaches. 1, you can try to do a food avoidance diet, which we try it sometimes depending on the family, but avoiding milk, maybe. Milk and egg, and gluten, and then some people do a 6 food elimination diet, which is basically peanuts and tree nuts, eggs, milk, wheat, soy, fish and shellfish, like, avoiding all this stuff.
Yeah, that's
like,
hard.
It's hard, and it sets kids up, and especially teenagers up.
For an eating disorder.
Exactly. Yep. And, like, you really, like, very rarely am I seeing it be of benefit.
Yeah.
So you could also do, like, a swallowed topical, like a swallowed steroid. The purpose of it is to, like, coat.
Yeah.
But again, that's kind of, like, temporary.
Right.
You can try a reflux medication. That has shown to be of benefit in some patients.
Yeah.
But then a lot of people are getting over to Dupixent, which is an injectable medication that works very well. It just kind of melts it away. It's also prescribed for atopic dermatitis.
Yeah. Yep.
You know? And so it works very well. It's awesome.
Yeah.
And so if we try one of these other things, then and they're not working, then we usually end up with Dupixent.
Yeah.
And I'm not a really big, like, I like to try all things like natural first.
Yeah.
But you know, those other options with EOE, they're not usually super effective.
Yeah.
And at the same time, you're dealing with often a child who like won't eat.
Yeah. Yep.
Or is very selective with
Right.
what they eat. And
Right.
that's what I mean when I say like picky eating. So many times there's something else going on.
Yep.
And so that's how I approach it.
Mm-hmm.
We talk through all the different options, shared decision making.
Yeah.
And, you know, but just unfortunately, the great treatment, Dupixent's a great treatment. It works great, but it's forever.
Yeah.
Or like indefinitely,
Yeah.
right? So, I mean, I am hopeful that, okay, let's try Dupixent. Let's
Yeah.
get all this calmed down.
Yeah.
And then hopefully over time, maybe this is something that's going to resolve. Just
Right.
like in many cases, eczema
Right.
over time.
Will resolve.
It's like, you
Yeah.
know, it lasts for a few years and then it kind of resolves. And so we'll trial patients off of the Dupixent. But you're exactly right. Like, it's like, what is this?
Yeah.
Where's this coming from?
Uh-huh. Yep. Okay, this is super interesting. I feel like I need to have you back because I would like to do this for another 30
I'll
minutes.
try to be less
about something
controversial
else.
next time.
No, I mean, you're saying all the things I think in my head, but I don't have any, you know, I'm a psychiatrist. It's like, what
So,
basis do I have for
I
this
think
kind of
I'm
stuff?
saying the things that most people think.
Yes, I agree with you.
And
most
that-
doctors, I think, believe that, but they don't want to say it out
They
loud.
don't want to say it. Some people don't want to say it. They
Mhm.
don't want to have the honest conversations. And I'll be very clear. I'm not saying don't vaccinate your child.
Correct.
Right?
Correct. Yep.
My children are vaccinated.
Same. Yep.
Did my children get the Hep B vaccine at birth? No, they did not.
Mhm.
Because I do not have Hep B.
Right.
They were not going to get it.
Yeah.
So I waited. And
Yeah.
actually, there's a study that demonstrates that if you wait a little bit, then when they are in their teen years, their immune response is more robust
Right.
than if you give it like straight
Right.
out the gate.
Right.
Which comes back to, we have to think about these little babies' immune systems and that
Yes.
transition from the in utero world to the ex utero world.
Right.
And not just an allergy, but also autoimmune conditions,
Yep.
obesity,
Yep.
all of these things.
Mhm. If I had known what I know now 10 years ago, you know?
My kids also didn't get bathed at birth. That's a whole different, because they're floating
Yeah.
around
Yep.
and then they come out and we start like
Yeah.
getting all that cheese off of them. Like,
Right.
no, it needs to stay on.
Uh-huh.
But it makes us comfortable to bathe them and they smell so
Exactly.
good. Thanks,
Uh-huh.
Johnson & Johnson.
Uh-huh.
Right? But there's actually no evidence
Mm-hmm.
to bathe your baby
Yep.
to prevent anything.
Yep.
We only do it because it makes them smell good. It makes
Right.
us feel better. But is it the right thing for that child?
Right.
And that's what we as doctors, even when it's not easy,
Yes.
that's our job. That's our responsibility
Yes.
to that child.
Yep. 100% agree. 100% agree. Okay. Tell people how to find you.
You can go to hoytallergy.com or you can go to Hoyt Food Allergy on all the socials.
And it's Hoyt.
Hoyt.
All right. Thanks for being here.
Thank you for having me.
Thank you for tuning in to this episode of the Little Brain Campaign podcast. If you enjoyed our conversation, give us a follow on your favorite podcast platform so you never miss an episode. Please take a moment to leave a review while you're still thinking about it. It really helps grow the podcast, and I love hearing from our listeners. See you next time.